what is the role of PCL? Is responsible for a femoral rollback during knee flexion, increases the quadriceps efficiency, it increases the motion that is required for climbing. It also inferior tibiofemoral contact and extension, that is at heel strike. Can we replicate this rollback predictably after a TKA with or without the PCL? Obviously, CR knees, that it is more bone preserving, patellar clunk, there's no post wear. Then there came out papers that compared CR and PS knees. This one said that there was an early improvement in stiffness at 1 year, but in the long 5 to 10 year follow-up, there was no difference between the two. This was again a meta-analysis that compared the CR and PS and found no difference in knee scores, radiological outcomes, and complications. When we compared there was no difference between the two. Reported that the PS scored more over CR as compared to WOMAC scores. When we comes, PS knees had better flexion, more flexion than the CR ones. And when we compared the kinematic, the post-op tibial and femoral alignment, tibial slope, joint line showed no difference. The femorotibial angle had better alignment in the PS group. Then they came out questions. Do CR knees have better proprioception? Do CR knees actually preserve the PCL in all of our patients? Or is there an iatrogenic risk of PCL injury? Can we do CR knees in all of our patients? Or do we have any alternatives in today's day and age to the conventional CR and PS? This paper studied and compared the proprioception in CR and PS knees. And in a sense, what they commented was, it is not only the PCL, but multiple anatomic structures, which include the muscle spindles, Golgi tendon organs, Golgi receptors, Pacinian corpuscles, Ruffini endings, and bare nerve endings, contribute to proprioception. So whichever structures have these structures into them can contribute to proprioception. They analyzed this by the direct and the indirect method. They also commented that the PCL denervation starts before the surgery. And in addition to multiple anatomic structures, vestibular and visual system also contribute to the proprioception. In a sense, TK itself improves knee proprioception regardless of CR or PS. And there was no difference between the two. This was again a very important paper. This paper studied the remnant of PCL footprint left behind after the bone cuts in a CR knee. As you can see, after a tibial cut, most of the PCL footprint at the tibial end was left intact. As compared to that, if you see the femoral attachment of the PCL, there is a substantial decrease in the footprint, 21.8% after doing the bone cuts. Hence, be very careful of injuring the PCL, especially on the femoral side. This was again a review article that stated the relative contraindications to do a CR knee. It states PCL insufficiency, posterolateral instability, varus more than 15 degrees, flexion deformity more than 20 degrees, inflammatory arthritis, extension mechanism deficiencies, patients with previous high tibial osteotomies, patients with unicompartmental knee arthroplasty, as we have seen earlier. So it's not really conceptual, but technical as to when can we avoid doing a CR knee, and we need to convert to a PS. So when do we convert on table from a CR to a PS option? In patients with severe flexion contracture, in patients with a steep slope preoperatively, thereby when we decrease the slope, it can up the joint line and tighten in flexion. When we have a small femoral component, that is a very lesser aspect ratio, and we need to select a smaller femoral component size where we can injure the PCL, especially the posterior chamfer cuts or the posterior cuts. Difficulties that we face when we are converting from CR to PS, a relatively high slope on the CR side. We have to correct that slope and also have a thicker polyethylene. So whenever we are doing a CR knee, check and recheck for the PCL integrity. Check for the scattered bundles after arthrotomy. Pull the ligament with a mosquito clamp. Check for abnormal stiffness or very lax PCL. Then you may convert to PS. Flexion tightness is a feature of CR knees. Therefore, cut less of distal femur. Otherwise, there will be a larger extension gap. in between sizes in CR knees, please go for a downsize or else we may tighten the flexion gap. It's exactly the reverse in PS. While doing your posterior and posterior chamfer cuts, you can arteriously injure the PCL. Hence, be very careful, especially in very small knees. When we have a posterior slope which is quite high, and we are now thinking of doing a PS knee, you can have an increase in flexion gap, and post and cam impingement can occur in extension. Closely follow up your CR knees. These are examples of a 10-year follow-up where you can see your knees going in slight hyperextension, which indicates PCL laxity or insufficiency. Do we have any other PCL substituting options in today's age? Yes, ultra-congruent poly has become a game changer. It is called the AS knee. And this is essentially to circumvent the PS drawbacks, that is post wear, bone sacrifice for the box, and the patellar clung. In design, it has an anterior build-up which ensures a femoral rollback in knee flexion. This paper compared the ultra-congruent versus the CR knee. And in essence, it states that there is similar stability in both these inserts. And ultra-congruent polys don't essentially increase the range of motion. It is the same as CR. This was a paper that compares the ultra-congruent versus the PS, which is quite promising. At a 5-year follow-up, it found that there is no difference in the two as far as range of motion and also the proms. Hence, my dear friends, it is time to personalize your treatment as per the patient. Check and recheck the balance and the integrity of the PCL, and always be ready to adapt on table whenever we are not satisfied with the same. I thank you for your patient hearing.